Good evening and good afternoon, everyone. It's an honor for me today to deliver my presentation. The lecture today about how to apply digital to my work as a maxillofacial surgeon. And in this presentation, I also tell you my work from 2015 when I left the public hospital. I would like to thank WEBCEPH and Dr. Kim for allowing me to be here. And many thanks to Dr. Đỗ Tiến Hải, the head of plastic surgery department at the National Hospital of Odonto-Stomatology, and Dr. Quang Dong, maxillofacial surgeon, who is extremely good at the digital field, and Dr. Viet Hoàng, the youngest, but very talented. 2015, as a young doctor, I was still confused with my orientation. And fortunately, I met one of my friends, my teacher, Dr. Besley. Together, we make a presentation at my hospital conference, a topic about surgical management of bloodstream malocclusion. And from then, I know that what I'm interested in, and I have started to learn to find textbook knowledge about the treatment of facial surgery for deformities. And later of that years, I attend one of the mod.
Please say your string, Dr. Phúc. We cannot see. We cannot see the string.
Why not?
Could you take up and share it again?
You don't see anything on my green share?
Yeah. We cannot see anything. Oh yeah. Now we can see it. And please make it as a presentation. Yes.
And how about now?
Yeah, it's okay. So I
now
think you have to do it.
I
again.
Go to the next slide. Do you see the next slide?
It is the first slide. Only one slide. We don't see the second slide.
Why not? I don't know how. I'm moving my slides.
No, we only see on the first slide.
So sorry for that. I need to stop share. I will try again.
We can go.
How about now? Does it move? Does it move to the next slide?
The slide of the website.
There is a pause.
I think this is the first slide. Maybe you should try to move to a couple of slides next. Maybe the second or the third one.
I'm doing your screen share. Oh. Okay, I will close my and open again.
You can say it again.
Yeah, I try. How about now?
Yes, yes.
But it move or not?
On 2015, yeah, it moved.
Yeah, it work now. Okay.
It's okay for now, I think.
But we will see your subscription.
Okay. I don't know why. Save range and how about now?
Yeah.
Yeah.
Okay, I think I will restart my computer before the webinar. It's a little bit slow video.
We still have a little thing from your presentation.
Now, what you see?
Only the first line.
The first line. And how about now?
Still like this.
You are really sharing pause. Okay, sorry for everyone. How can I do now?
Could you send me the presentation? I will share it for you.
It's about 2 over 3 gigabytes. Calling.
Could you take up and rejoin the webinar?
Yes, I will try.
Dear Dr. Đỗ Tiến Hải and Dr. Đồng Ngọc Quang, could you share anything about orthognathic surgery before Dr. Phúc coming again?
It's quite in hurry, so I think maybe it's only take a couple of minutes. Maybe we should wait for Dr. Phúc. And of course, I have something to share, but I mean, it's not really formal to do it here. Dr. Viet Hoang, maybe I think maybe you should share your screen. I mean something random, maybe or Google, for example, just to test the software. Maybe there's a problem with the software. I'm not sure about it.
The software. Yeah, for me, I think it's okay. Do you see the my sharing?
Yeah, very clearly,
Yeah,
very
okay.
perfect.
So, okay, so please share the presentation again, Dr. Phúc.
Yeah, sorry,
about
Dr.
now?
Phúc, we don't see anything.
We don't
Just
see
a
anything.
blank screen.
Just the first slide.
No, we don't see
No,
anything.
nothing.
Why not?
We cannot see anything.
Maybe
And now?
maybe you. I think maybe you should you just share the screen like this. Yes, like this, and then you
just share the
you move
screen
the
like this.
and move the slide one by one. Yeah.
Yeah.
Okay. Okay.
Okay, please say it again.
Mm, how about now?
No.
Yeah, we see it. I
We
see it.
we see your prescription.
Yeah. Okay.
Okay.
How about now?
Yes. Yeah. We can see it. So I think we should start now.
Okay, sorry everyone. I start again. My topic today we talk about how to apply technology, the digital technology in orthognathic surgery. So thank you, Dr. Hải, Dr. Quang Dong, and Dr. Viet Hoàng. I will tell you something about me. When I was a young doctor in 2015, I was confused.
We still have a little some black area on the slide.
Black area on the slide.
Could you check on the messenger I send you?
Yeah. Why? Black area. Why? No. That is first time I met the situation like that.
I think you just show the PowerPoint without the presentation. Please share only PowerPoint.
Like that. Do you see anything now?
I think Dr. Viet Hoàng want to say that you just share the screen and then you move the slide one by one, not
I know.
not in the
How
in the play
now?
mode.
No, we cannot.
No,
we don't see anything.
Is it right? It moved. Is it move?
Yeah, it's okay. It's okay. It's okay. Just carry on. I think you just start the talk.
Yeah. Do you see
I cannot see anything. Just a black screen.
you cannot see anything? Dr. Hải?
Yeah. Yes. Black screen.
Kỹ ra. Okay, how can I do now? How about now, Dr. Hải? Hello.
Yeah, it's okay, it's okay. Oh.
Dr. Hải, do you see anything? Do you see my presentation?
Yeah, but not clearly.
Not really.
Yeah, not clearly.
Okay. It's okay now. It's okay now.
Yeah.
You can present your presentation.
Does it move?
Yes. Yes.
It's good now.
Yeah. Okay.
Good enough.
Okay, I start my presentation now. 2015, I have an opportunity to make a presentation with Dr. Besley about the management of treatment large-tree malocclusion. It's a very interesting experience for me. And at that time, I have a love with the Orthognathic, so I try to learn to read textbook and to go around the world to study. And at the end of that years, I have an opportunity to attend ICOMS, a very famous conference of oral and maxillofacial surgery. And in 2016, I have a chance to go to St. Vincent Hospital and work with Dr. Dimitris. He's an expert in oral maxillofacial surgery, and he do a lot of temporal mandible joint surgery. He also the startup of OMX Solution. This is a medical company provides the customized place, customized implant for the maxillofacial. And now you can now is the Maxillofacial. It means the OMX Solution closed, and he changed the name to the Maxillofacial. So you can go to the internet and find this company. And this is the first time I have opportunity to work in the 3D environment, in 3D planning, and study how to to plan 3D surgical planning. From 2015 to 2018, I went around the world, go to the Maxillofacial Center to work with the doctor here and study how they apply application, how apply the lineage digital to the treatment. And in 2019, I have a memorable I attend a contest for young presenters. I have a chance to present my work, from the 3D planning of orthognathic surgery, and maybe my topic, my presentation met the criteria of the organizer, so I I got the top prize for the best presenter. 2020 is a very difficult year for me, for us, and everyone in the world. So my work stopped, and I have time to experience a few very modern in medical. This is the visualization in medicine. This means you use the 3D imaging to describe, to make a video, to describe, to modify for technique for application you want to share. And 2021, I have a YouTube channel. I bought some 3D video into this channel, and this is one of the video Dr. Simbo sent me the idea, and I make for him a video about the orthodontist. Yes, that's that I can do for doctor, for surgeon, and now we come back my presentation today. This is a very common work for the young surgeon. When I when the teacher, my boss give me the chance to do the work like this, I very happy and enthusiastic with this kind of work. This kind of work include you transfer the relation of the maxilla and mandible to the articulators, cut and move them into the last one occlusion, fix them and make a wafer occlusal wafer for the surgery. This is the surgery wafers. It make on the left, it make from the acrylic resin, and on the right, this wafer make from the thermoplastic materials. You can make it soften when you put it in the hot water. And this is the traditional treatment planning, the series of treatment planning of the traditional. First, clinical examination and record the jaw relation, transfer the relation to the articulator, and from here to here, it's very easy to make an error. And when you have an error over here, you go to the next step, especially the model surgery. You make the model surgery, and you discover something wrong at this step, and you must repeat all step again. But now the develop of the computer tomography, especially the CBCT, is very important for the maxillofacial and medical field. With CBCTs, you can record the relation of the mandible and the maxillas. you can superimpose the dental cast, the soft tissues, and this is the basic for the orthognathic blending. There are a lot of software now to blend orthognathic surgery. This is a Siemens O&O. This is a software I have to use. And now the latest version of this is a Roland CMF, and one of the famous software, Dolphin 3D. And all of them, when you want to use, you need to pay the money, and that costs a lot of money. So in Vietnam, maybe some doctors, some surgeons can pay the money for that kind of software. So now we can use the open source software, and the most famous is Orthognathic. But if you want to use all the power of this software, you need to combine with other applications like 3D lasers, MATLAB, NetFab, and Blender. When you combine all of the information of the patient, but include the soft tissues, the bones, the height, the dental cast, you can do the virtual surgeon. You can do the virtual surgeries. And when you move the bone, the soft tissues change, and you can repeat it many times as you want until you reach that you want to do. And finally, you transfer your plan on the software to the operation room. You make the surgical scraper or surgical splint, or maybe you make the cutting guide for this case. And more than you can make the customized place for the patient, even the prosthesis for the patient. And now I introduce the virtual surgical planning workflow. First, you need to explain for the patient. You need to examine the patient, explain the patient how will you do, and what the patient needs to do. You order the CBCT for the patient. After CBCT, you have a set of data, and you combine up the data to the 3D model. When you have 3D model, you need the segmentation function to divide the skull into the maxilla to the mandibles. Now you have the STL files, and next you need to 3D modeling function. At this step, you can match the dental cast. You do the virtual surgery, and for example here, this is the PSSO surgery. And finally, we transfer that kind of information that of your plan to the operation room by make the scraper, make the cutting guides with the 3D printing or 3D CAD cam. Now, talk about the CBCT. This is the new era in diagnosis and treatment planning. Someone asked me why we shouldn't use the CT scan. I give you some reason. First, the CBCT gives the very quality of image of the 3D model with a very close dose of radiation. When you order the picture to make the CT scan, the patient must lie in the machine, and this is the result. The other doctor give me the CT, the result of CTs, and the patient is at the wrong postures, and I can't do anything. I can't plan with this kind of position. You need to take the CBC to take the CT at the natural head position with relax up lift and and the soft tissues. And the final reason, the CBCT is very, it had a lot of kinds with and you can buy now at that time. At this time, you can buy a CBCT at your office, at your dental clinic, at your the center, the mall, and the medium center. If you want to have a CT scan, you need a large center. You need work for a hospital. However, when you take the CBCT, you need to focus on some features. First, the field of view. As you see here, this is a patient take a CBCT just with a small FOVs, and with that we can plan a surgical planning. We need a large FOV for maxillofacial surgery. And what field of view should we use in the maxillofacial and orthognathic surgery? This FOV is the minimum for the orthognathic surgery, but if some patients have a big head, or the patient have the deformity in the craniofacial, you need a bigger FOVs. The next is the vessel. If you are a fan of computer, a fan of games, you also hear about the pixel. This is the resolution of 2D environment, and the vessel is the resolution of 3D dimension. With the higher resolution, you have the smooth 3D model. The lower, that is the result you get. And the last one is the artifacts. This means when you take the CBCT or even the CT, you need remove the metal in your mouth, especially the dental round or dental ridge, or even the races. The races of the orthodontist may make an artifact. Sometimes I need to take a CBCT with the most modern to reduce the artifact of the races. Here, yes, this is the artifact of the races when I take the CBCT. After taking the CBCTs, you have a lot of 5 DCM. It depends how many file are there. It depends on the FOVs, and the resolution of this CBCT. Over here, I have 1,000 DCM file. It means I have 1000 layer. After that, we need a function or a software to combine 1000 DCM to make a 3D model. All software can do that, but if you don't have the money to pay for the software, you can do the open source software like 3D Laser. With 3D Laser, you can do a lot of things. But if you just make to have a view of skull, to have a view of anatomy, and you need more a line software, you can use the Oasis lines. After you this software, you can segment the skull into two bar, or you have the STL file. With STL file, this is the international file for 3D, and you can rinse the model with STL files. And now this is a skull I rinse before I do a surgery. It make me remember an example to apply the digital, to apply 3D model in my work. Maybe in 8 years ago, when I was a young doctor, I met a patient with a big ameloblastoma, and the patient needs to cut the bone like that. So my boss bring the model for the patient and bending the blades for the patient. This kind of work help we reduce the time in the surgery room, and we have time. We have we have view to bend the leg very parallel with the other side. Six years ago, I met a patient with a symmetry facial. I take a CBCT, and you see in the CBCT, after you make the 3D model, you can see why he have the asymmetry facial. This is a bone. Okay. This over here. So I divide the bone into two sides and mirror the left side into the right side. And now we can see the bone where we need to cut to balance two sides of the mandible. But the problem is, how can we transfer this information into the operation room? I also try to make a surgical guide, just like that. It masks the bone I have to cut. It have the handle over here, too easy to use. However, in 2016, I don't have enough technology to make the surgical guide. I only have the FDM technologies to ring the model. I will tell you what is FDM, and this guy we couldn't use in the surgical field. However, when we bring the model, when we bring the surgical guide, I have imagine about how one I will cut and where I cut. I do the surgery. I did a surgery and cut the bone. Luckily, the bone I cut is equal to the bone I blend in the 3D blending. Thinking from here, I wonder myself, how can I make the surgical guide? How can I transfer perfectly what the information, the plan I do in my software. The next I will tell you at the next before the last the next slide. But now I come back the application of the model. In this slide, I bring the 3D model, and I bring the 3D models and make the condylar repositioning. I very love this because it's very important with me in Viet surgery. I try to keep the the bone have the condyles in the right position. I will tell you later. Now I talk about the FDM technologies. This is my FDM printer. This is the material. I call it the filament, and it is nozzles. The material will be heated and will extrude from here to bring the model. This is the this picture describes what I said. This is the filament into this box, and it has, after that it go to the nozzle, and the nozzle will move and extrude to the base. Now you can see the video describe it better. With this kind of rings, with this kind of 3D printers, you can see the layer. It's very rough, and we can do it. We can use it in the operation room because you can do sterilize, and the accuracy is very close. The accuracy, the resolution of this kind of print is just 0.5 millimeter, but we need more. And with this kind of print, with this kind of 3D printers, we just use this to print the model to have a view before you surgery, or maybe you make the graphic prototype model. This is the condylar I make when I was in Australia with Dr. Dimitris. It's the memory of us. And if you want to make the guide to make the model with the higher accuracies, you need the SLA printer. And this is the first printer I have experienced the firm lab through. In this kind of printer, it have a liquid in the tank, and it have the line below the tank. When the base go down, the line make the resin, the liquid, harder. And after the process, all the model were viewed, and the accuracy were very high. You can make the surgical guide, you can make the sling, you can make the model, the dental model, and they have a lot of resin to ring anything. But if you want to use it for the operation, you need the a specialist resin. This is the surgical guide resin for surgery. You can sterilize it with the high temperatures. And with that, you make the digital wafer. Yes, this is one of the first digital wafer I did. But in the from lab to at that time, it's very expensive. About I don't remember. It's just 2,000 400 million Vietnam đồng. So I don't have money to pay for that, but I want to make the surgical guide by myself in my office. So I try to a lot of many printer from other manufacturer, and that's of my first printer from one house companies. And this is I bought it on 2017. And you know, this printer is cheaper than the money I bought the surgical guide resin, but it worked. This is my from my to make the surgical guides in 2017. Yes, a guy and make. Now we come back the CBCT. After you have a model, after you have a 3D scout like that, you need to segmentation. You need to segmentation function. You must divide the skull into two parts, the maxilla and the mandible, if you want to do the virtual planning. And because with CBCT, as you know, as I said before, it has the artifact of the phrases, and the quality of the tip is very close. So you can do anything. You can do the surgical plan with the with data. So you need to to have the model. There are many kinds to make the digital model. First time I make the traditional impression with antennas and have a stone model. I use a desktop scanner to digitalize my cast. This is the indirect solution. If you want to have a direct solution, you need to have an intraoral scan. With intraoral scan, you have the very high resolution tip, and you have the occlusion. If you export with the PLY or OBJ file, you have the color of the tip and the gum. Okay, and when you have that information, you mask the dental cast into the skull, and you finish the repair operation. Now you move to the surgical virtual. There, yes, this is the surgical simulation in my software. On the left side, the BSS surgery, and on the right side, the anterior segmental ostomy. You can do it. After you have the perfect plan, the next step, you transfer the information into the operation room by make the surgical wafer. Yeah, we need this is the upper, the lower. You have a wafer here. You subtract the upper, subtract the lower. You have the surgical link and make the SLA rings to have the surgical wafer. Yes, this is the surgical guide I bring from SLA technologies. And as I said before, in my practice, I always do the condylar positioning device for BSSO case. And in the past, I tried to make the the guide for the condylar positioning the device, the condylar positioning device by the SLA printer. But sometimes it doesn't work because it's very easy to wreck. So I think I need the CAD/CAM technologies, but the cost for CAD/CAM technologies is very high, especially when you want to do a big model. You can use the CAD/CAM with the small, but when you want to have the big model like that, you need the to pay more money. And after you have a wafer, you try it with the dental cast. And this is my case after I use the condylar repositioning device and fix the bone with the wafer. And 3-day follow-up, I don't use the intermaxillary fixation, but with the condylar repositioning device, the result never change, and patient can keep the orthognathic wafer again without any change after 3 days. So the advantage of 3D printing: first, less time consuming, and it degrade the member for resurgical workup to fabrication to make the sling fabrication. For me, an example, I do it from clinical examination, take the CBCT, design the wafer, ring it, and do the surgery. And it's increase the accuracy of resurgical workup, and so it decrease the risk of human error, because if you prepare perfect, you can decrease the errors, the risk you can do in the surgery, because the information on the wafer, on the cutting guide, improve the predictability of the surgical outcomes, reduction the possible laboratory delays. Next, I will talk some experience of me about the virtual surgical planning. Now we start with the a simple case first. This is the symbol. This is a patient have a very reduction mandible. The fact that she have the indication to make true-jaw surgery level 1 for the maxilla and PSSO for the mandible. However, she's scared about doing the surgery. He refused. He just want to make something invasive. So he should just make the simple orthodontist, and after that do a xenoplasty. This is a very difficult case. If you already doing a xenoplasty, you will know the distance for slide is just approximate 6 to 8 millimeter. But in this case, the patient need move the string, the bone of string to the forward about 10, 15, or even 20 millimeter to improve her face. Apparently, so the perfect I couldn't do for her, but I tried to make best. I tried to make the virtual surgical cut the chin, the bone of chin, and keep the middle bone. And this is the pace for the bone slide to forward to forward 10 millimeter in this case. Yes, you see, I cut the bone here, but I try to keep the bone in the middle. After that, I slide the left side and the right side into the forward, and it will start the bone here to to have the fixation. Yes, this is the photo in the surgical room. And now, not perfect, but enough for her to be happy. This is the X-ray before and after do the surgery, and in this case I improved for her about 12 millimeter. And next case, this is a patient, the last one patient, and you need to see she might with the gum export in mouth. The overbite and overset is very large. Especially she told me she had already 4 years with orthodontist, and now this is the result. So the first premolar missing over here. You see the first premolar, she don't have. This is the cephalomatrix. This is the panorama view, panoramic view. Now she wants to improve her smile. She wants to improve her face. When I suggest the level 1 osteotomy, and after the surgery, you need orthodontic treatment. She refused because she don't want to wear the braces, and she afraid that the big surgical. Here she want me to make a very invasive surgery for her. It's very difficult because in the last one patient you can do the ASO, the anterior segmentation osteotomy, but she don't have the remolar, the base for the ASO do, and the space between the canines and the second remolar is very close. First, in my experience, when I try to move some case like that to the top, I discover beside it go over the overset and overbite could be improved after the surgery. So I think I can do the ASO for her in this case, but the problem is if I cut over here, I may be make the harmful for the teeth nearby. So I try the virtual blending. Okay, when I cut, when I move off, as you see, the overset and overbite improve. So I decided treatment line is anterior segmentation osteotomy, the genoplasty, and orthodontic treatment after that if she wants the perfect. The problem is how I cut exactly like the virtual surgical. I try to make the cutting guide. Oh, at that time, 2017, I don't have any experience with this kind of cutting guides. So I just decide what I think in my mind. And after many design, I show that. Yeah, this is my first design for cutting guide. But when in the operation, it's very difficult to handle. So and I make the orthognathic wafer for the patient. Luckily, I can do the surgical successful. I can make the cut between between two teeth and without any harmful. Yes, this is the tip before and after the surgery. The overbite and overset, are improved. And experience in this case, the ASO can perform without space if you have a cutting guide. And my first cutting guide is difficult to manipulate. So next case I will design a handle like that. And this is the next case. The patient, the last one, occlusion with the midline deviation. 25, the tip number 25 missing, and 13 missing over here. And we can see the canal over here on the right side. And this is the panoramic X-ray. The canal in the bone. So this is the reason she don't have the canals. And on the right, on the left side, if we cut the bone over here, we will damage the sinus. Okay, I try again. Decide what I should to avoid. Okay, make the cutting guide. Yes. And in this case, I try to make the handle too easy for me to take it. You see, and try to bring the 3D model. Try to the cutting guide and perform the surgery. Yeah, with the cutting guide, I can make the very accurate cut, accurate osteotomy, and take out the canal without damage the bone at the buccal side. And I can reverse the sinus without perforation. And you see on the right photo, the buccal the buccal bone on the right side is still here. Okay, forget. And this is the one with follow-up. the wound is very good condition. Okay, after this case, I discovered that my cutting guide just indicates where I need to cut, not guide the direction. And I need to remove the bone to move the cutting part. So I make a lot of time. I do with a lot of time after I cut. And I think about the fully guide for cutting bone. It means it guides me where I cut and how much bone I must remove. This is a case in 2021 when I use, at this time I don't use the simulate O&O again. I moved to use the blender. I still perform the virtual surgical after I move the bone into the right position. I know how much bone I will cut and the position I cut. So I make this guy. But the cutting guy with bone support is not accuracy. When I read the textbook, compare the guy with tooth support, with bone support, and mucosa support. The tooth support is very more accuracy. So I try to make the guy with tooth support like that. First, I have a sling with tooth support and have the horn over here, because this horn is the same position compared with the maxilla with the cutting guy. So I can, where after drill a horn in over here, I expose the bone and put the cutting guys, fit it. It's very passy to the bone. And now I have direction, I have the volume of bone. I perform the surgery. You hear this is the cut. I put the saw exactly over here and cut the bone. That's the bone I cut on the right side. You hear just the horn I drilled. The bone I remove very smooth because I just used the guide. And this is the bone I remove at the middle. The bone I remove on the left side. The bone I remove at the middle, and all the bone I remove after remove the bone. It's very easy to to move the cutting bone, and I try to make it to the to lace it to the surgical wafer, and the bone is very fast, and I don't need to do more like remove bone, like remove the and everyone will ask me, it is the CAD/CAM technologies. This is a CAD/CAM cutting guy. The fact that I couldn't, I don't have, because as I said before, the cost is very high, and in Vietnam it may be not a good solution when you use the cutting guy with CAD/CAM technology. And this is the way I do. I use my SLA printer, use the castable resin. It means the castable resin, and print it and send it to the laboratory, and they make the metal cutting guide for me and perform the surgery. Yes. So now I apply that kind of guide to my works, the cutting guides, the surgical wafer, the cadaver repositioning device for the BSO. Okay, the last one I will tell about a little bit about the medical visualization. When I discover what I can do with the blender, I can, for example, in this line, I can communicate with the orthodontist where I want the orthodontist move the tip, move the tip before I make the surgery. Like that, this is the case with the mandible deviation. And she asked me, now what should I do? So I show her why the tip move like that. Okay, and now she just follows the guides of this video and move the tip into the position like that before making the surgery. And I also make the 3D video for the young surgeon to describe what the technique will do in the surgery. Like that, this is the BSSO technique. Yeah, you can see how the surgeon do in a surgery. Very yes, this is the video I make. And if you go to my YouTube channel, you can see some video about okay, it doesn't work. Some video about the maxillofacial, some video about the orthognathic surgery. Okay, if you have time, you go to my YouTube channel, give me a surprise, a like. I say I will come back as soon as possible and do a lot of video for doctor, for student who interested in. Yeah, thank you for your attention. That's all thing I want to share today.
Thanks so much, Dr. Phúc Lâm, for the wonderful presentation. Now, could I invite Dr. Đỗ Tiến Hải and Dr. Quang Dong for any idea or something about this presentation or about orthodontic surgery? Please, Dr. Đỗ Tiến Hải.
Thank you, Viet Hoàng. First of all, I want to thank you the webinar of Dr. Phúc. I think that this is an interesting webinar, and as you know, the cutting guide for spleen is very important for surgeon. So in webinar, really? Can you hear me?
Yeah, yeah.
Yes, yes.
I want to ask Dr. Phúc. Dr. Phúc?
Yes. Yeah, yeah. I'm here.
Yes. I want to talk about the software.
Software.
You use two software. The first is 3D.
Are you finished?
I want to ask you about software you use for design the spleen. Which software?
As I talk in my webinar, the first software I use in my work is Simland O&O. Why I use this software? It's very simple because this is the software Dr. Dimitris give me to improve my work. So that is the first software I do, and I must combine with other software like Maxillofacial. But now the cutting guide, the final cutting guide you see in my webinar, I do it by Blender, not Orthogon Blender, just Blender. Blender it look like the Photoshop in 3D environment. You can do anything if you have the idea. I try to use the auto on Blender. It's it's the application developed from Blender from a doctor in Brazil. But sometimes I have the ideas. I want to develop this idea, but the software is not make the idea so much. So I try to Blender, and the 3D video you see at the last slide, I also make by Blender. So now from here, I will make the Blender in my work. But in the past, I use the Simland O&O. Yeah, that's my.
Thank you for your answer.
Thanks, Dr. Hải. Could I know more sharing from you about the orthodontic surgery?
In my department, maybe 1 year ago, we used a manual to make the spleen. When I have a patient, we do and we make and we use a stone model in articulator, and we do it by manual. But at this time, we research and we use Odonto software to make a spleen. Yeah. So this webinar we talk about 3D digital. So I think that I just talk about 3D and the technique. Maybe we have a new webinar. So that's so.
Dr.
Yeah.
So I want to invite Dr. Quang for your idea and your comment about this webinar and your sharing about the orthodontic surgery.
Yeah, thank you for inviting me to this webinar. First of all, I would like to thank Dr. Phúc for a very excellent presentation. So I personally, I am an maxillofacial surgeon, and I personally, I also the user of Ortho on Blender, the software that Dr. Phúc has mentioned. I have the first question for Dr. Phúc is how do you find the final occlusion on the software? How do you do it, or do you use the dental cast model?
Yes. When I use the Simland O&O before, it had the function to find the final occlusion. But now, when I mask the dental cast into the mandible and maxilla, I try to find the final occlusion by the dental cast outside the software, scan it, and and move it into the software blender and to make the the surgical wafer. This means the dental scars.
Yeah, thank you very much. It is, to be honest, it is exactly the way I do. So
Yes.
yes, I also scan. I mean, I use my hands to find the final occlusion on the cast, and then I scan it with the intraoral scan. And I found out that there is many participants from Latin America. So I think many of you have heard about Orthog on Blender by Cicero Moraes. And
Yeah.
And in that software there is a function to find the final occlusion. However, I like the software very much, but for the final occlusion function, I don't really trust it. So I still use the cast, and then I use the intraoral scan to determine to copy, to transfer the final occlusion from the reality to the software. Okay,
Yes,
I
that's
have
the
the
way
second. Yeah,
Okay,
I have the
okay.
second question for the cutting guy. For the cutting guy for the level 1 osteotomy, I saw that you print the polymer cutting guide, and then you send it to the laboratory to make the metal cutting guide. So my question is, why do you have to do it? Is polymer cutting guide is not strong enough?
I have tried some other idea about cutting guides with the surgical guide resin, and I have two problem with that. First, sometimes it not fit it not fit exactly to the bone, and when you make the strong reel to fit the guide, sometimes it broken, and all of it means all of the thing you repair were disappeared. And the second reason, when it's very difficult when you make sometimes, because the bone is not smooth. Sometimes it start when I put the cutting guide, and when I push some the trunks very strong, the cutting guide is not strong enough to keep the shape before. So I try to make the cutting guide by metal, but I couldn't use the CAD/CAM surgery. That's the reason I try to use the castable resin, the castable to make the round for the dental round. I design, print it, and send it to the laboratory. They do slide to make a round, the metal round, and I have the cutting guide. I can sterilize it. I can put it with the strong. I can drill without any fear about breaking. Yeah, that's my reason.
So if you make the metal guide from the laboratory, how much does it cost?
Yeah. Yes. So first, because I work for a dental system, they have the laboratory. So in all the patient, I do the surgery like that. I don't need to pay the money. But I think it's not cheap. It's not expensive. It's just you make the the long wrist, but easier. So I will ask them how much. But now I don't need to pay the money. But I think it's cheaper than the CAD CAM technology.
Okay, thank you very much.
Yeah.
Thanks, Dr. Quang, for wonderful question and discussion. So do we have another question from the participant? Yeah, Dr. Phúc, we have one question. Have you ever tried to make a surgical guide for the mandibular BSSO?
I tried 1 or 2 times, but I couldn't do it because the field of the the surgical field of BSO is very small, and it's difficult to put the cutting guide. I also tried the textbook, tried the paper in the in the internet and copy their design, but I still don't. I still put the guide exactly, and it makes me very difficult to do. So that's the reason I don't have any more care about the PS or with cutting guide. But in my mind, I still thinking about that. But now I don't have the idea. If you have an idea, give me. Thank you.
So Dr. Hải and Dr. Quang, could you have answered the question? Did you use the surgical guide for the BSSO or not? Dr. Quang, did you do the surgical guide for the mandibular BSSO?
No, I don't. Actually, for me, the the guide for the BSSO is not really necessary, because for if you want a guide, so it should be the guide for the condylar positioning, like Dr. Phúc has shown you. However, my technique is a little bit different, so so I don't use that. For the cutting specifically, I think we don't need the surgical guide for that. And if you are familiar with using the 3D software and manufacturing the cutting guide, you need some space. You need enough room to put the guide into the surgical field. And when we do the BSSO, the field is enough, but it's not too roomy, not spacey, and the bone is also a little bit thinner than when you do the mandibular resection or when you do the level 1 osteotomy. So fitting the guide, I have never done it, but I think if you try to fit the guide for the BSSO, it will be very difficult and unnecessary, in my opinion.
Yeah. Thanks so much, Dr. Quang. So do we have any question? Okay. So now, if we don't have any question, I want to share something. So today, thanks to Dr. Phúc because of the wonderful and impressive webinar for the WEBCEPH. And now we have my WEBCEPH. The WEBCEPH team has the certificate for you. So now we will end the webinar today at this time. So thanks for Dr. Phúc, Dr. Hải, and Dr. Quang because of the speaker and panelists for this webinar. Hope we can discuss more about another subject in the future, and hope Dr. Hai and Dr. Quang we can have a webinar for orthodontic surgery, also for WEBCEPH in the future.
You should talk with the Dr. Kim about invite Dr. Wang or Dr. Hai make the presentation for us.
Yeah.
They very excellent surgeon.
Yeah. For on participant, and I want to introduce a little about the next webinar. The next webinar will be on the 17th May next month about the surgery in facial contouring using osteotomy and implant. So today, thanks for all participants. Thanks for Dr. Phúc, Dr. Hai, and Dr. Quang. Hope we can discuss more and have another lecture in another subject next time. Thanks so much.
Thanks so much.
Thank you.
Thank you, everyone.
Thank you.
Thank
Thank you,
you.
everyone.
Dr. Wang and Dr. Hai. Yes.
Good night, everybody.
Good night.
Thank you.